Okay, this series of lectures is kind of review, catch up on some content that some of you may have been working with a lot. Some of you may have been working with only some pieces of it. So this is just a kind of crash review in some things so that you're maybe somewhat near in content or ready to go forward next semester in content. So for some of these things, you'll have been using this material a lot, and for some of them you won't. This is about pharmacology. That we're going to start with some basic med administration information and then pharmacokinetics. And then we're going to hit just a few med classes for each body system that you might come up with. So first of all, medication administration, you need to remember the 5 rights of med administration: right medication, right dose, right route, right time, right patient. Okay, so that's the 5 rights. We should check the 5 rights 3 times before we give medications. Medications need to be documented appropriately. Documentation systems don't always function as well as we'd like them to. Scan at the bedside med administration has become nearly universal in acute care because of safety, but it can have it can cause some issues with efficiency, especially if the system doesn't work well. So it's really, really important that you use the system as it's designed. If it's not possible to correctly scan a med at the bedside, make sure that you're not skipping that verification process. No matter the system for administration or documentation, as a nurse, you're responsible for the 5 rights. Am I giving the right medicine in the right amount, right dose, by the right route, to the right patient at the right time? So always remember the 5 rights. Some other tips on order safety: there are limits on who's allowed to take verbal orders, and verbal orders should only be given in situations where there's not another option. Most facilities have now moved to provider order entry, so providers have to enter the order correctly or have to enter the order themselves. That correctly thing was brought up another potential issue. Some of those systems, they're great in theory, but they can be unwieldy and difficult. And so we may have orders that are actually entered incorrectly. So sometimes a nurse is following up with the provider. What is it actually that you wanted? But we do want to avoid taking verbal orders when we don't have options. If verbal orders have to be given, we need to repeat them back. Make sure we're using closed loop communication. And then chart verbal order read back to make so that we're documenting, yes, I received this as a verbal order. I repeated it back, and that provider verified that was the order. We also need to make sure we're clarifying any illegible or questionable orders. If the order doesn't seem to make sense, question it. That is your responsibility. If you give a medication, even if it is ordered by the provider, if you give a medication and as a nurse, you should have known that it could be potentially harmful to the patient, you are also responsible. So you're responsible for your practice, even in following orders. Some other med safety things: make sure that we use the correct abbreviations, use approved abbreviations only. Things like QID and QD, if those are written too quickly or even a typo, they can be mixed up, and there's a big difference between those, things like that. So use only approved abbreviations. Using zeros, you always lead, you never trail. So we always put a 0 in front of the decimal if we're giving a less than 1 unit of whatever we're giving. So 0.7 milliliters is written as 0.7, not as 0.7. Get in that habit. And we never trail. If we're giving 7 milliliters, we are going to give 7, not 7.0. Because that trailing, if the decimal is missed, we can have an order, we can have a serious med error. So make sure always lead, never trail. Use 2 patient identifiers. Typically name and date of birth are the most common. Identify lookalike meds and make sure that you have ways to avoid accidentally administering the wrong medication. Again, that goes back to scanning at the bedside. And if you can't scan at the bedside, visually verify. And I would almost say that out loud. I am giving acetaminophen 650 milligrams, acetaminophen 650 milligrams, because taking that extra time helps avoid making that error. Something that did not happen a lot until probably midway through my career or even later is reconciling meds. Medications need to be reconciled across the continuum of care. So patients come in, we need to find out what home meds are they taking. The provider is supposed to review that list and determine which ones they need to take during that admission. When they leave, any new prescriptions or changes to those meds should be communicated clearly to the patient, but also to other providers prescribing for that patient. And we need to make sure that those prescriptions follow the patient so that they don't have duplicate orders or taking too much of the same medication because 2 different people ordered it, or they're missing something entirely. And for almost every one of these potential safety pitfalls, I actually have horror stories because I've been a nurse for 28 years. So you may have some horror stories, but I'm not going to talk about any of those right now. I want to talk about the Redondo case. This week, and if you're listening to this in a future year, this is 2022. This week, a nurse was convicted of criminal charges for medication error. And there were multiple systemic issues that contributed to that error. There was a paralyzing agent that was available in an Omnicell, I believe. The nurse was not working on her usual unit. She was floated as a help all or resource nurse. She was asked to go down to radiology to administer medication to a patient in radiology. The Omnicell there were integration issues with the EHR, and so they were having to override a lot of the meds that they took out of the Omnicell. So when you go in and you put your patient's information in, and then you go look for the med, it says this med's not ordered for this patient. They were having to override that a lot, very, very, very frequently, because it wasn't communicating well with their system. And there was no barcode scanning system available in radiology. And so the nurse was supposed to give midazolam. I believe that it was ordered by trade name Versed. She went to the computer or to the Omnicell and she entered under that patient and she started spelling Versed. Something popped up. She took it, got the med out. She had not administered Versed very often in her career because of where she worked. And she got out vecuronium instead, which is a paralyzing agent. She was supposed to give Versed, which is benzo, or midazolam is benzo, gave vecuronium, which is a paralyzing agent instead. She also was not qualified to give IV sedation and monitor, but was told she didn't have to be. And that the patient didn't have to be monitored because there wasn't a hospital policy in place. So there's a lot of system things. But the nurse also failed to visually verify. She failed to take the time to actually read the vial that she pulled out of that Omnicell, and administered a paralyzing agent to a patient who was then left alone in a room for about an hour. And when the radiology staff went to take her in for her PET scan, she was found dead. So that nurse has now faced criminal charges. And there's a lot of opinions about whether that should be the case or not. But you need to understand that that is a reality now. That precedent has been set. So no matter how rushed you are, take the time to actually read your medication labels. Actually make sure you know what you're giving. And the other piece is that if you're in a facility where you're not able to practice safely, find another job. You need to protect your license, but also protect your freedom. Okay, in the next section, we're going to talk about basic pharmacokinetics and pharmacology.